Warning, the following slides may contain numbers. I would welcome a few questions as we go along if it would help in your understanding. Oregon Task Force on Universal Healthcare identified three major problems with our current healthcare system: unsustainable cost, unworkable complexity, and by the way, cost and complexity sometimes go hand in hand, but not all the stressful effects of complexity can be measured in dollars. Anxiety of walking into a provider office or facility, having no ability to know what it will cost, the stress of having to decipher complex bills, worry and uncertainty of which bills will be paid by insurance, desperation of the effect on meeting family budgets, intimidation of complexity, which discourages many from seeking care at all. Third major problem identified by the task force is that in the US, we divide people into groups which have very different access to healthcare. Related to the problem of inequitable access is a shortage of providers, particularly in rural, primary, and behavioral areas. 4 state-level reform alternatives will be compared against how well they address the three major problems. The alternatives are mandatory purchase of private insurance, further expansion of Medicaid, public option, which competes with private insurance, and a simplified payment structure or single payer. In order to demonstrate the difference between the 4 alternatives, a flow chart of the financial system can help show how the current system works and can help describe how reform alternatives would affect the major problems. This flow chart may look complex, but it is actually simplified to only show some of the major components. We will look at this flow chart in more detail after we start with a look at history. First, a little definition. All residents are potential patients. On the other side of the flow chart, professional medical providers are any person, facility, organization which provides diagnosis or treatment, including physicians, specialists, therapists, nurses, hospitals, clinics, technicians, and pharmacists. A little as a century ago, virtually all professional medical care was accomplished by direct financial exchange between each patient and each provider. At this simple level, it is easy to see that this is a circular arrangement where everything adds up. The money the patient pays is the same as the doctor receives for the services provided to residents in this case. Adding one more level of complexity, charitable philanthropy has always played some role in healthcare. There are 2 types of philanthropy: donations of money and voluntary donations of unpaid time. 100 years ago, and for that matter, since the beginning of human time, most care was provided at home by family members or close friends. The first hospitals, many of them started by religious volunteers, were founded to provide care for people who had no family to care for them. Family and volunteer care still does exist at some level, but since this flowchart is a financial one, it will only show private cash donations paid for the care of others, or donations which are raised to build facilities or purchase major equipment. Here is an estimate that 100 years ago, about 98% of healthcare costs purchased from providers was paid for directly by the patient or their family. About 2% was paid for by charitable donations, primarily given to hospitals. Looking ahead over time at private donations to medical providers, donations peaked in about the 1980s as a percentage of total healthcare costs and have stayed about the same level since then. In any financial system, there are always some losses due to overhead. Up until the 1940s, medical system financial overhead in the United States was probably about 3%. Nothing else consisted of the doctor having to keep track of payments going to the bank to deposit checks and cash received. In thinking of overhead, it is useful to think that for every dollar of actual healthcare needed, residents would need to spend $1.03, since they also need to cover the cost of the overhead. As we shall see, overhead has been going up quite a lot since 1920. By the late 1940s, most professional care was still provided by direct financial transaction between the patient and provider. The use of middlemen was growing in use. State and county level programs, including temporary assistance for people without income, was coming into play. Major medical insurance, similar to fire insurance on a home, was for rare but expensive events, which many people would not experience in their lifetime. With the addition of middlemen, overhead doubled from about 3% to about 6%. Through the 50s, 60s, and 70s, reliance on middlemen increased significantly. Direct payments fell to less than 1/4 of total cost. Employer-sponsored medical insurance continued taking a larger role in between the patient and the medical providers. Employers got involved because of IRS rulings that allowed employees to receive healthcare benefits tax-free when arranged through an employer. For many, insurance became regarded as a convenient way, if a more expensive way, to pay for regular medical bills, rather than just for major care. Federal government, which had almost no role in healthcare prior to 1960, began assessing taxes to pay for Medicare and Medicaid, which grew quickly to cover about 1/3 of all cost. Private donations had gone up to about 4% of cost by this time. Providers, the proliferation of different insurance policies, public programs required a major increase in billing staff. In this time period, total overhead had doubled again to about 12%. Jumping from 1980 to 2019, we see the continued trend toward middlemen in the form of federal, state, local governments through private insurance, including employer-sponsored plans, and the medical portion of liability insurance policies. In reading this flow chart, the percentages on the right side of the flow chart are how providers get paid, mostly by middlemen. For instance, 32% of provider income comes from private insurance plans, 22% from Medicare, about 17% comes from Medicaid coordinated care organizations. The percentages on the left side show how residents pay for healthcare, mostly through state resident payments to middlemen. The largest payments are through federal general fund taxes and through employer-based plans. Private donations still exist and are shown on the bottom row. In 2019, private donations were just a little below 6%, close to what they had been in 1980. Direct payments have fallen from the majority of all payments to just 11.3% currently. About 4% is co-pays, deductibles, and co-insurance. The rest is to cover services which were not insured. For example, about half of dental and optical customers choose to pay cash. Most durable and non-durable supplies are purchased without insurance. Here is a 60-year trend for direct payment, also known as out-of-pocket cost. Note that although out-of-pocket cost may still be increasing as a dollar amount because of recent increases in copays and deductibles, continues to decline as a percentage of overall healthcare cost. Moving up from there, private insurance consists of both regular health insurance, medical portion of liability insurers, such as workers' comp, auto insurance, home insurance, medical liability insurance. Combined regular and liability insurance carriers comprise about 35.5% of all healthcare payments. Medicaid CCOs are specialized private insurance companies covering just under 17% of all costs. It could be higher in states like Oregon with Medicare expansion. Looking at how residents currently pay for regular private insurance, most private medical insurance comes through an employer, though some people do purchase their own private policies. Employer sponsored policies come from workers foregoing wages in favor of medical benefits. The private individual policies shown here include purchases of Medigap and Marketplace. The long-term graph of private insurance shows a dip in the late 60s as Medicare and Medicaid kicked in. The recent decline in private insurance may reflect the change from employment jobs to the gig economy, unfortunately. The dip in 2020 is, of course, COVID related. Looking at government programs, Medicare and Medicaid are well known and account for most purchase of health care made through government. Medicare accounts for about 22% of all healthcare payments to providers, but note that Medicare payroll taxes and premiums only amount to about 11% of cost, meaning that Medicare is only about 1/2 funded. The remaining half of Medicare is paid out of the general fund, creating an obligation to federal taxpayers. Medicaid is financed through a combination of federal and state general fund taxes. As shown in the total general fund box, about 37% of all health care is currently funded through general fund tax liability. Although Medicare and Medicaid are the major government programs, members of the Oregon Universal Care Task Force identified over 40 individual government funding programs related to healthcare. Many of these programs could be eliminated with a comprehensive, simplified payment system, by the way. Here are the major trends since 1960 and who pays providers. While direct pay out-of-pocket payments have declined, private insurance, Medicare, and Medicaid have generally increased. A blip in public health activity with COVID coincides with a major upset to all payments in 2020 and 21. Here is the 60-year trend in how residents pay for healthcare, mostly to middlemen. You see that the leading expenditure through funding healthcare middlemen is now general income tax to the general fund, then private insurance, direct pay, Medicare payroll tax, private donations, and Medicare premiums. In the upper right corner is direct care, mostly funded through government programs. About 4.3% of all care is provided directly to specifically eligible residents. This is done by the VA, Indian Health Service, specific public health programs, other direct care provided by correctional facilities, schools, universities, and other organizations. And direct care would be continued by most of us to actually continue on and not be part of a universal healthcare system. As you might have guessed, total system overhead has doubled again to about 25%, meaning that we must pay about $125 to receive $100 in care, or $125,000 in order to purchase $100,000 of medical care. This flowchart relies heavily on the Senate, on the SB 770 Task Force actuarial report to show the location of examples. And what the actuarial report showed that, and this is based on reports by Dr. Shao and others, the billing overhead for providers is about 20%. So in calculating the overhead, about 80% of all costs goes through the billing. And so 80% times 20%, meaning that the overhead due to provider billing is about 16%. Looking at private health insurers, the next largest overhead, according to the National Health Expenditure accounts, they average about 12% of total healthcare costs. But that percentage only covers to about 1/3. So the total overhead as a percentage of total cost is about 4%. If you look at the providers box, one of the factors adding to complexity and injustice is that providers get paid a very different amount depending on who the patient is. Assuming that the average price of services is $1, Medicare pays just 81 cents on the dollar. Medicaid pays 69 cents on the dollar. Providers must make up for these losses by charging private insurance patients average of $1.37 on the dollar. Providers who see too many Medicaid and Medicare patients cannot cover the costs of staying open. So many providers limit the number of new Medicare and Medicaid patients they will accept. Some refuse to see these patients at all. This caste system of different payments is one of the two major sources which contribute to injustice in the healthcare system. The other is the fact that about half of all residents receive their insurance through an employer. Despite decades of trying to fix it, employment in jobs which offer healthcare benefits is historically discriminatory in its effect. So, congratulations. You've just covered an immense amount of material. And before I get into comparisons, are there any quick questions?
You can use the like hand raise if you wish.
Yeah, there were some in the chat I saw.
Okay. Can you read them, Fritz? I'm not picking up my chat here.
Yeah, we can't see it.
Sure, that's fine. So let's see. Ann Jones asks if you can share your slides. So she put her
Yes.
information in there. Yeah. So she put her information in the chat. So Warren, you can grab that out of there. And then Susan Malero asked Warren, what about people with disabled as mental health care and how that works? That just depends upon whether they're in the Medicaid or the Medicare program, correct?
Yes, and the National Health Expenditure accounts for which I relied on for much of this information does not break out disabled populations by itself, and also does not break out behavioral expenditures separately. I wish it did, because that would be very useful information.
Okay, great. Kathy Sword asks, does the chart you showed include the effect of prescriptions / pharmaceuticals?
Yes, and it's included in a number of ways. It's included in the amount that hospitals use, the amount that's administered in doctors' offices, and also included in the amount that's purchased from what most of us think as retail pharmacies, be they brick and mortar or online.
Okay, great. Thanks, Warren. And I see you have your hand up.
Yeah, quick question. I think a lot of people would.
You just went on mute.
A lot of people would. I meant to take my hand down. A lot of people would be surprised to learn that Medicare is only half funded. I knew that the Part D program, the drug program, is dipping into the federal budget. I did not realize that regular Medicare beneficiaries, besides being defrauded by Advantage plans, is also only half funded. So we are, has there never been any talk of increasing the FICA tax to cover that?
Well, I think, what we've seen is that the trustees for years have been trying to cry tears to get people to look at that situation. But nothing has been done, and we're still kind of heading into the uncertainty of what will happen. I think, as you say, many people are not aware that Medicare is only half funded. I often hear, when I'm speaking, I hear people say, doggone it, I paid my whole life for this. And the truth is, that they paid about half of the actual cost. And I don't begrudge anybody any benefits, but for those of us who need to do the math on it, we really need to be thinking about how to make that add up.
Well, each of us only pays 1.45%. The employer pays 1.45%. So that's 2.9% tax for that. So, which is public health insurance. It was supposed to be. Now it's being just wrecked. But which makes it even more egregious that we're allowing Medicare Advantage to defraud the system, and where this ACO REACH program will privatize and monetize. I can't imagine how CMS is getting away with this, with that, given the financial facts behind.
I'll handle two more questions from Charlotte and Rich, and then I'll move on.
I just had a comment. It is a question. Is part of why this topic of the trust fund is dipping into the general fund to be able to pay for current recipients of Medicare, didn't that trust fund lose a lot of money when George W. Bush took, during his administration, somehow or other, money was taken to pay for the wars, all the military action? Do you know if that's part of it?
I'm not prepared to address that.
Thank you.
Sorry. Rich?
Yes, Warren, is the cap, meaning the amount of income that is taxed for Social Security, is that cap the same for Medicare? And if so, would dramatically increasing the level of salary that is taxed significantly fund the program?
No, it is not capped the way that Social Security is, and in fact, beginning, I think, in 2013, the rate was raised on people who making above, I forget the number, but about $160,000 were charged a surtax on their income, and this, by the way, is earned income. It's not charged. The Medicare tax is not charged on things like rent, investment income, and royalties, things like that, which could raise a little more money. Well, I'm going to jump ahead into the comparisons, and then we can come back and have more questions. I really appreciate these questions. So now we get back to the comparison of 4 reform alternatives against the problems of high cost, complexity, and inequitable access. And we begin with mandatory private insurance, meaning that anyone not on Medicare, Medicaid, or employer insurance would have to purchase private insurance. Forcing uninsured or underinsured individuals onto mandatory private insurance could possibly give few people better access to health care, but a significant cost. And it might help providers because more people would pay the $1.37 rate, but it would not do anything to address the major existing problems of overall cost, complexity in the system, or inequitable access. So in general, Medicaid has been expanding continuously to cover more and more people. Oregon, in particular, has become the master of using special Medicaid grants to expand people who are eligible for Medicaid. Further expansion of Medicaid has several effects. If the expansion is designed for government, quote, government, to pick up more of the cost, then presumably income taxes will need to increase to meet the increased federal obligation. Medicaid expansion could reduce overhead slightly because CTOs have marginally lower overhead than other private insurance, I should say. However, as long as Medicaid only pays 69 cents on the dollar, any and every increase in the number of patients eligible for care at this significantly below provider cost likely to compound the problem of providers refusing to serve Medicaid patients, and in fact is likely to generally aggravate the supply of providers. Public options generally refer to a publicly run insurance company which competes with private insurance. Some people have suggested that a publicly run insurance company should be able to provide better service at less money, though this has not been proven. One specific version of public option being considered in Oregon would allow people to buy into Medicaid either through a public insurance company or private insurance companies using lower Medicaid reimbursement rates. Public option, which competes with private insurance, actually adds to the problem of complexity by increasing the number of system components while eliminating none. A 2021 healthcare financing report by the Colorado School of Public Health, and I'll give a shout out to all the people here from Colorado, estimated that continuing a multi-payer system with the addition of a new public option would actually increase complexity and add 2 to 3% to the total cost of healthcare. Considering that, we could estimate that raising the overhead from 25% to about 28%, any program configured as an optional Medicaid buy-in could actually contribute to the problem of finding providers willing to see patients at below actual cost of delivery. Many people are still rabid believers in public options. Many ideas along this line have been tried. So far, all have failed. They appeal to relatively few residents. They save less money than many might hope. Many insurance companies are already nonprofits. Insurance profits are less than most people think anyway. But the real Achilles heel of public options is adverse selection. One of the things that the task force in Oregon learned from its actuarial studies, that savings are from simplification, not governmentalization per se. Here is estimated savings from Optimus, our actuarial consultant, showing, as the earlier graph did, that most saving comes from provider administrative costs. A public option could not save anything on commissions and marketing, since it would still have to market for customers. Insurance margin potentially would go down, but it's actually a pretty low dollar amount. Just because you're not paying profit doesn't mean that you have to, profit is a way to attract investors. A public option would most likely have to sell bonds. So depending on the rate of interest that they would have to pay on the bonds, their margins may actually be lower or higher. Fraud, waste, and abuse really can be an advantage for like a single payer type system, but a public option is just one of many payers and doesn't really have the potential for the same reduction in fraud, waste, and abuse. Cost of healthcare, getting back to that Achilles heel, the cost of healthcare is concentrated in relatively few people. 2017, the top 1% of claims averaged 236,000, highest individual claims well into the millions. Takes about 400 people with almost no claims to equal one big claim. For insurance carriers, it almost doesn't matter what they charge in premiums. Their success or failure is highly dependent on who they insure. For simplification, consider that the bottom 80% of the population averages $2,400 in medical costs per year. The top 20% averages $44,000. When private insurance compete with a public option, all they need to do is shed 3% of their high-cost patients into the public option to lower their cost by 10%, raise the public option cost by 10%. As a healthier people flock to the lower private premiums, the public option premiums spiral up to the point of no return. Private insurance companies can shed expensive patients in a way that no public option can or would. Finally, we come to the alternative, a simplified payment structure or single payer. In this structure, all existing payment components would be replaced with one common payment structure. Simplified payment structure, such as a single payer system, would address the major problems of cost, complexity, and inequity. Total cost could be reduced by 12 to 16% by reducing the overhead without changing the income of those who actually provide patient care. The complexity of billing would largely be eliminated by eliminating per patient billing. While the current system values a provider's time differently depending on whether they are stitching a finger or checking for a sprained ankle, the new system would be based on paying for provider availability to see what other kind of patient shows up. Major causes of inequity would be eliminated because providers would be paid $1 on the dollar regardless of who they see, and because obtaining health care would no longer be linked to employment. Compared with the other alternatives, single payer model clearly offers a path forward for future generations, which none of the other alternatives can come close to. Any board or commission charged with addressing universal care truly needs to give priority consideration to this alternative. Speaking of future generations, Ben and Noah hope that our generation will make the changes for their generation. Thank you for your patience in covering a lot of territory this evening. Email me for your certificates of mastery on healthcare economics. I will now be happy to facilitate open dialogue and questions. Thank you.
Did we get people on the screen or not? Oh, yeah. So
as soon as we get people on the screen so I can see them, I'll start calling some names. But if people would raise their hand electronically, that'll be a little bit easier, but questions for Warren?
I stumped the panel.
Well, I want to thank you for including inequity and injustice in this. These words are not always used, and it's such a big part of the problem.
Mark,
So-
I see Ray with his hand up.
What are we looking at for taxes that we pay?
Well, that's a subject that we really didn't cover tonight.
No, okay.
But it is a good question, and certainly we've given a lot of consideration in Oregon to how to design the right kind of tax. I personally believe that the best tax leaves most people paying more or less the same as they do now. The more big winners and big losers that you design into a tax collection system means the bigger fights that you're going to have on your hands. Hope that helps.
Yep.
I see.
Rich had his hand up.
Warren, only if it's appropriate for tonight, but for those of us who are not closely tracking Oregon, can you offer a quick assessment of where that group is that you're working a part of?
Yes. I served on the task force, and along with John Santa, who is also on the call, we helped write the actual recommendations from the task force, urging the legislature and the governor to appoint a governing board to begin putting together the details of universal health care and ideally a single payer system. Through heroic efforts of our chief sponsor, Senator Manning of Eugene, it made it all the way through the legislature, and it was signed by the governor, but the governor's signing letter was disturbingly lukewarm, and kind of said, well, I don't really know what you're trying to do here, and maybe a single payer isn't that good of an idea. So the governor we're worried, is kind of walking back the recommendation, the task force recommendation of a single payer type system. So that's actually parallel with some things that are happening in the state of Washington, where they have a commission that's looking at all kinds of alternatives and not just single payer. So I wrote a paper on which tonight's presentation is based, kind of reminding people that there's really a big difference between these alternatives. And if you really want to look at something serious and long-term, you've really got to put single payer kind of at the head of the list of considerations. So we're waiting on the governor to make appointments. The governor is kind of dragging feet, waiting for more direction from the legislature to decide whether to appoint people who know about Medicaid, Medicaid waivers and can get those extended, or whether they're looking at people who know about the single payer system. I hope that helps, Rich.
We'll go to Anne and then Thomas. Anne?
Warren, does your flow chart account for the public subsidies for purchasing private insurance? on the exchanges and the public subsidies in tax expenditures to employers who provide insurance as employer-sponsored insurance?
Excellent question, and the answer is I ran out of ink and space to put it on the paper.
Okay.
Those would be, if I were to make a bigger chart, the issues with the marketplace and with the you mentioned Medicare Advantage system sucking money out of the public trust. And I would love to provide more detail, but in the hopes of simplification, I did not. You're right on every count that those are true, but they weren't included in the chart.
Okay. So if I could be allowed a follow-up. So PNHP's statement that approximately 2/3 of health spending is already public is probably close to the mark via all the public programs and all the subsidies to private insurance.
It kind of depends on what you divide by. If you include in the total cost things like investment in buildings and major equipment and direct care, you're going to see a lower percentage. I think 2/3 is probably too high. And when you consider the out-of-pocket expenses, if you're only looking at insurance, maybe that number would be right, but that seems high to me. So, but depends on what they're including.
I mean, it includes public programs, the cost of public programs, plus the subsidies to provide commercial insurance.
Yeah,
I think that's how they define it.
Yeah, I've got more numbers on that I didn't
Okay.
show, and would be happy to share them.
Okay, thanks.
So to Thomas and then Bill.
Well, thank you, Warren. One major observation, it looks like your grandsons haven't aged a bit. You need to update some of those pictures. You really nailed it tonight. What a wonderful presentation. And you did it with an economic evaluation, which differs from a financial evaluation. And what you really demonstrated was that it's feasible to move forward with a single payer system. And it's probably the only system that's really feasible. We came to the same conclusion that you had with the work that we've done in trying to deal with the national single payer system. And that has to do, of course, with high quality care at a reasonable cost. And we have to simplify the system, and we have to defragment the system to allow access to all with having the same access. One of the dilemmas with Medicaid is that we see taking the healthcare services out of the state and the Medicaid system and put it into a national system, but we still need to have the social determinants of healthcare being local. Medicare cannot accomplish that. So we still go forward with a lot of our work at a national basis. And I think some original ideas are coming from people like Ralph Nader and Tom Hartman and Public Citizen. And we're communicating with some of these good folks and coming together with a financial analysis, which really tells us where the money will come from, and rather than that it's just feasible. So the real question that comes out is, what hope do we have for a state reform as compared to a national form to get rid of these damn PBMs and make it a national PBM, a government PBM? How do we get rid of the private insurance companies and this crazy stuff with Medicare Advantage? Well, one has a monopsony, and essentially the only purchaser of drugs and of healthcare services is one group. So national versus state. Do you have some comments about that?
No, I came to the conclusion that some kind of national single payer system is probably not politically feasible. I think it can be demonstrated at a state level, which is why I'm putting my time there. The supposed or the so-called SABUCA bill, the state-based national waivers, would really help. But more people are going to have to get behind that with some muscle, I think, before it takes off. So very good to see you, Tom, and I look forward to catching up more about Colorado. So in the meantime, Bill, have you got a question?
Yeah, thank you.
Bill, you're muted.
Forgot about that. Okay. Yeah. Thank you, Warren. Wondering if you could say some more about the governing board, what it's tasked with. Does it have any authority for whatever it comes up with? What can it do, and what is it, or is it just advisory? So if you'd say some more about that.
Okay, and I speak in the presence of John Santa, who helped design that. But basically, what ended up passing the legislature is the authority to have a 9-member board aimed more at the technical side than the political side, and the appointment of a executive director and potential staff. So our John and I on the task force, we thought we needed more technical muscle. So that's largely the difference between the last task force and this governing board. The governing board does not have the power. It has the power to make recommendations to the legislature, and it would be the structure for the continuing operation of the universal care administration, but it would require continuing approvals by the legislature to actually enact. Is that did I direct myself to your questions?
And so, is it actually governing?
Well, that's a name. It is it is the board that would eventually govern the system.
Eventually, okay.
Yes, it would be the exact same people, and has all the rules of how long they serve and their overlapping terms and things. So there's a lot of things in place, but some people have kind of gotten cold feet, and we need to kind of nudge that along. So thank you, Bill. Charlotte.
My question directly follows what your answer was. What do you think the chances are of presenting your information that you just shared with us with a couple of people from the legislature and a couple of people from the task force, and have a meeting with the governor? Why won't she let herself be educated? Do you know?
Well, I think there is a lot of momentum in a different direction. And Oregon is very proud of its ability to attract more federal money, which may or may not be sustainable. Right. And so to me, that's kind of shorter term. And one of the things that we really lack in Oregon, a number of people have pointed out, is as far as let's say a big name vision for Oregon healthcare. You know, we have to go back to Governor Kitzhaber, and unfortunately, there's nobody who's risen above that as far as creating the vision. I have hopes that something can happen. I think Senator Steiner will be a key player, as will the governor, and as will Senator Manning. So I have hopes, and certainly I put this information together in the hopes that some of it would find its way into the decision makers' hands.
And then a second part of my question, and I don't know if this is too political, and if you don't want to address it, I understand. My understanding, that the governing board writes the recommendations you described, presents it to the legislature, so they have it in January 2027. They either act on it, they don't act on it, or like Measure 111, the constitutional amendment idea was put to the voters. Have you any understanding of how likely that might be?
Well, I'm glad you mentioned Measure 111, because I actually think it may be a key to getting to the legislature. That the legislature really should be worried. We've passed this thing. We now have an obligation of the state taxpayers to do something, but nobody knows what it is or how much trouble we're in, and we should probably be more worried than we really are. So I think that can be used as a kind of lever in looking to the state governing people and saying, what are we going to do about Measure 111?
This is a step to do it.
Yeah, the idea of a initiative petition may be something that needs to happen if the legislature won't. People who have done that, it's a lot of work.
I've done it with Betty Johnson and Mike Huntington, and what I was thinking of is how likely.
The point I wanted to make is there are legislators on both sides of the aisle who say, for God's sakes, don't give this to the legislature. We screw everything up. Run it as an initiative petition because you can define what the rules are. And so that is one appeal to considering an initiative petition. So I think
I'm not thinking of an initiative, because 111 was an initiative. It was what it called a referendum from the legislature to put something on the ballot. You don't think that's very likely?
Oh, I think it is in some ways inevitable, particularly for the funding part. The legislature would almost definitely not enact a new tax without a statewide vote. And even if they did, somebody would start an initiative petition to put it to a statewide vote. So I think ultimately your case is a good one. Initiative petition or a referred petition is both real. Thanks, Charlotte. John, I see you've got your hand up and you can refute everything I've said.
Well, I'm sorry my camera doesn't work, but that's a blessing for you all, actually. Well, first of all, Warren, I would say from the outset, I think I could agree with virtually everything you said. And I think you've summarized our situation well. A couple of comments that I thought might help the audience. Think of this governance board as a startup. And, in a startup, you have a pretty good idea that this is going to work. The idea folks have made their case. This could work. This could work. And as Warren said earlier, you need a more technically oriented group of people who know how to put these things together and see if you actually can make them work and what you need to do to make them work. And on the private side, about 2/3 of startups fail for good reasons. So I didn't think of this as, well, definitely this is going to happen, but rather there's going to be some real world conversations knowing that this could happen. This could happen. This could be done. The numbers add up, if not favor a single payer solution. So one of the things the startup would the bill instructs them to do is to sit down with the delivery system and really negotiate on what would the administrative savings be. sit down with Medicare and ask them, would it be possible for Oregon to have a single Medicare plan, if you will, a single Medicare Advantage plan, single payer Medicare, I'm sorry, Advantage plan, you know, ideas of that sort. So we'll see. The problem is that, you know, the bill has, I think, given them the structure of a startup, but not the funding that will be needed to really hire enough people who have the depth and breadth to make this work. Though who knows? It may be if board members themselves will be willing to dedicate time, and if volunteers like who are on this call and people who have the expertise like Warren does, you know, would be able to keep this going. Just a political statement here in Oregon. Realize we have a wonderful governor, but she is elected by a minority. You know, there was a three-way race for governor here. She beat the Republican candidate by, I think, two percentage points, 42 to 40 or something like that, with a moderate independent, you know, getting the rest of the vote. So, you know, I'm sure she feels that she needs to be careful. Her priorities are clear. Her priorities are homelessness, mental health, and education. And you know, it's not a from the top reform of healthcare. And she also, for a variety of reasons, decided during the campaign to make it clear that she was going to change management of the Oregon Health Authority. So the Oregon Health Authority, who runs, you know, the state system, still awaits a leader to be appointed. So, you know, we have a lot of flux, and even Senator Manning did a wonderful job, but he recently announced that he's going to run for Secretary of State. And Senator Steiner, who Warren mentioned earlier, has announced that she's going to run for the treasurer. So one wonders how much time and attention are they going to have, you know, for this issue. So I am thrilled that you're getting this kind of message out, Warren. Keep it up. You know, for me, the emphasis is our current system is built to avoid sick people. As one seasoned financial person said to me, John, in the 40 years I've been doing this, it's always easiest to figure out a strategy to, quote, improve, unquote, your patient mix, i.e. get the healthy folks and get rid of the sick folks. That's a lot easier to do than actually to get rid of administrative costs, get more efficient, or improve the quality of healthcare. The easiest thing is just to avoid the sick people. And until a message like Warren presented tonight gets across to the public, the billions of dollars every year that are being actively used to avoid the sick, that's why rural Oregon's in trouble. Look at those numbers. That's why rural Oregon is in trouble. So terrific presentation, Warren. Thank you.
Thanks, John. And to add a little bit to your comment, because I think it's relevant, politicians are afraid of big change. And you mentioned startups, and you know, a certain percentage of private business startups fail. I have run various startups, and in general, you don't take a lot of chances when you're in private business. If a problem is too big to take a risk on, then you build a pilot plant or you run an experiment. And the analogy here is that, you know, maybe we don't want to bet 16% tax on all income for all services if we can run a pilot program of, say, a 3% tax that covers all cancers, all checking for cancers, all diabetes, all ALS. I mean, some of the big things that really scare people. Maybe we could run a pilot program at a lower tax rate that people might be more willing to go for it. So that's kind of an add-on I can make to your comments about wanting to avoid risk of startups. So I don't see any other hands, and Mark, we've certainly filled the hour. I've appreciated the conversation with everybody, and look forward to more.